Thank you very much, Jonathan. It's a pleasure to be here. Thanks for being here in such great numbers. We will start with a question. What is the 30-day mortality after a heart failure hospitalization? This is looking at Canadian data of 100 patients that are discharged after a heart failure hospitalization. How many will be deceased at 30 days? So the audience is mixed on this, the favorite being 10%. So the burden of heart failure in Canada, I think you've seen this slide before. You can see here the mortality at 1 year is 25%, and the 30-day mortality for those who chose 10%, a little under, actually 16% of patients will be dead after a heart failure hospitalization. So think about that. 16 of 100 patients that are discharged are not going to survive beyond that first month. And that's why we're talking today about the urgency of taking care of this patient population. In particular, this is a slide that Peter showed you, we have this very vulnerable period in that first few days to weeks after the patient is discharged. You can see here that high mortality is really very early on, and that's when the patient is very vulnerable. So we cannot wait for weeks or months to engage patients in their care and to optimize patient care. We must act early. So there's certain factors that will affect the early outcome after a heart failure hospitalization. And I think we need to look at these factors and to see if some of these are potentially modifiable. So first of all, this is again Canadian data that shows us that about 34% of patients will not even see a physician after a hospitalization, and this is within 1 year. So patients are hospitalized, they're discharged, they don't see a physician. Well, not surprisingly, they have the highest 1-year mortality. And here you see that the lowest 1-year mortality comes with the patients who are actually followed by both a specialist and a general practitioner. Is that modifiable? Absolutely. There's really no good reason why 34% of patients hospitalized with heart failure are not seen by a physician within 1 year. We see similar data coming out of the UK. This looked at patients who were seen in hospital prior to discharge, this time by a heart failure team, and you can see in green versus in black that there's a benefit of survival in patients who were seen by a heart failure team prior to discharge. So we can do even better if we don't even wait for the patient to be discharged. So why is that? Well, it's likely multifactorial. Patients are educated. Patients understand, they're more aware. Patients are supported if they're seen by a heart failure team. But also there's one other factor. We know that there tends to be underutilization of evidence-based therapy in heart failure patients. And we do know that heart failure team or patients followed by heart failure teams tend to have better optimization of these evidence-based therapies. And not surprisingly, we see something very similar, that if patients are treated appropriately with ACE inhibitors, beta blockers, and MRA at the time of discharge, they fare better than the patients in the dotted line at the bottom that are treated without ACE inhibitors, beta blockers, or MRA. And this is seen in continuity here from the registry, the Qualify registry, a large international registry of which we were part of in Canada, that if you look at baseline optimal treatment or adherence to treatment by physicians, so at baseline, if you start off with good therapy and you follow patients for 18 months, that it remains consistent, that patients that are on good optimal therapy in red fare better than those that are on poor optimal therapy in green. And this lasts out to 18 months, and this is positive for all-cause death and cardiovascular death. So patients need to be treated appropriately as early as possible. You've seen some data about the role of heart rate. Peter showed you how heart rate, and actually Jonathan showed you as well, how high heart rate is actually nefarious for the heart. And we want to control that high heart rate. And here you see data from Ontario showing that over 9,000 patients discharged from heart failure hospitalization, if they were discharged at the time of discharge, if their heart rate was over 70, so between 71 and 80, they had a hazard ratio for 30-day mortality of 1.2, and this went up and up so that patients with a heart rate over 90 at the time of discharge had a hazard ratio of 30-day mortality of 1.88 versus the reference group with a heart rate of 61 over 70. So high heart rate at discharge is another factor associated with poor prognosis or poor outcome after heart failure hospitalization. This is seen also in this European data that if you follow these patients out to 1 year and they are discharged with a high heart rate, this maintains. The lower the heart rate is at the time of discharge, the better the prognosis is in terms of survival out at 1 year. So you may say, well, you've showed us that it's urgent to treat patients and that their most critical period is in that 1 month. Do any of our medications actually act that early? So Jonathan showed you in the Copernicus trial that it actually took 3 months for the curves to diverge when you use beta blockers. So the outcomes really start to change after 3 months. But fortunately, what we've seen more recently in the Paradigm HF trial is that actually the endpoint of heart failure hospitalization starts to diverge very early after the use of sacubitril valsartan in a stable heart failure population. So we do have data to show us that early on, if you treat patients, this is a stable heart failure population, so it's not a population that is in hospital or just recently discharged, but nonetheless, we can see that our medication can have an effect early on, and as well, we see that with ivabradine. So these are patients who were treated with either ivabradine or placebo after first hospitalization for heart failure, and you can see how quickly the curves diverge, so that out to 3 months, you see significant benefit. And actually, you start to see that benefit very early. You see that at 1 month, you already have a significant p-value showing that the curves have diverged significantly very early on. So you can actually get control of these patients with proper medical therapy very early and actually impact that early period post-discharge from hospital. Finally, more thought-provoking kind of data. This is actually just a registry, not a randomized study, but it's a registry from 6 centers that shows that actually if they used ivabradine and beta blockers during hospitalization, so forget now waiting until the patient is discharged, but how about pushing this a little bit earlier on and treating these patients while they're in hospital? And in this case, the probability of survival was improved significantly if patients were treated in hospital prior to discharge with both ivabradine and beta blockers. And Jonathan showed you something similar in his data, which is a small series, but nonetheless interesting, that he started patients on ivabradine who could not tolerate beta blockers while they were in hospital and had good outcomes in that patient population as well. So this kind of data is starting to emerge. We don't have any randomized controlled trials telling us that we should be starting these medications while patients are in hospital, but it is certainly thought-provoking and leads us to wonder if we can really treat patients earlier on. What has been shown is that there is inertia of optimizing medical therapy once patients are discharged. But actually, during the hospitalization period, and this is from studies, international studies really from around the world, that we can see that while patients are hospitalized, this is actually the period where you see the greatest changes in medical therapy, whether it's ACE inhibitors, beta blockers, or MRAs. If you look at the at admission, which is the sort of dotted kind of columns versus the solid columns at discharge, you can see that most of these medications did go up, or the use of these medications did go up while patients were in hospital. So probably that is really the best time to capture patients while you have access to them while they're in hospital before they go out into the community and where there tends to be less or more physician inertia in terms of optimizing medical therapy. So thought-provoking. We don't have randomized controlled data to say, to support this, but certainly you can understand, I think you can see that there is a vulnerable period for the patient immediately after hospitalization, and that we really should start thinking about initiating our therapies early, and that's really the urgency that we're dealing with in heart failure to try to prevent some of these early mortalities. So to conclude, mortality and readmissions are high after discharge for heart failure. We know that better adherence to guideline-recommended therapies can improve outcomes, And probably, as we're going to start to see data emerging, hospitalization is the moment where you could really make a difference to try to optimize your patient therapies. We know there are effective therapies out there. There's a great randomized control trial with medical therapies. These medications need to be used. Thank you.